Welcome everybody. Thank you for joining us today. This is the second talk in a series of talks that we're going to have this week on COVID-19 by the various faculty at UH West Oʻahu. So these are, you can see a list of all the different talks that are going on this week. If you missed a talk or you want to go back and check out something that was said in one of these talks, please feel free to email me and I'll send you a link. It will be posted on the UH West Oʻahu's library YouTube channel. So do go ahead and check that out if you are interested and you missed one of the talks. All right. So today I'm going to be talking about the mathematics of a pandemic. Now, before I start, I just want to have a little disclaimer that I'm not an expert in COVID-19, and nor am I a medical doctor. So don't take medical advice from me. Dr. Rick, who spoke this afternoon, is a medical doctor, so he would be the one you'd want to take advice from. I am a mathematician that does mathematical models of epidemiology. I've looked at things such as rat lungworm disease, dengue, and Ebola. So, but I do know enough about COVID-19 that I can intersperse that throughout my talk today. But what I want to share today is that there's a lot of news happening right now with COVID-19, and we want us all to sort of understand and get a better idea of what's happening around us, just so we're better educated when we see things in the news and we can understand what's really happening. When we talk about a disease, especially right now, two big questions that people are asking are, how deadly is the disease and how contagious is a disease? So the first one, how deadly a disease, we're measuring that with what's called a case fatality rate. And how contagious the disease is measured with something called a basic reproductive number, or R0. And you may have remembered, if you're there this afternoon, Dr. Rick did mention R0. We'll talk about that later, but we'll focus our attention right now on the case fatality rate. Sometimes it's called the case fatality ratio. Now, all that is just simply the number of people who die from a disease divided by the number of people that are infected with the disease. Okay, straightforward enough. So it's the ratio of the number of people that die versus the number of people that are infected. So for example, if we have 100 people that are infected with the disease and 10 of them die, what would the case fatality ratio be? And go ahead and put it in the chat, those of you that are tuning in live. Somebody. Feel free to write it in the chat. Yeah, 1 to 10. Yeah, 1 over 10 or 10%. Awesome, great. All right, we got a lot of math experts here. So the case fatality rate is 10 over 100 times 100%. So that's 10%. Good. Awesome job, everybody. But this is okay for many diseases, but sometimes the case fatality rate, there's a problem finding that. Why, and again, you can answer in the chat, why do you think there might be a problem with the case fatality rate, especially with something like COVID-19? Yeah, the true infection rate of asymptomatic patients, yes. So with COVID-19, what we're finding out right now, and we're in the middle of the disease, so there's still a whole lot that scientists don't know, but we're finding out that we don't know if people have the disease, because people can be contagious and infected, but they look normal and they feel normal. And that's what we call asymptomatic. And so if there's people that look healthy, we're not going to test them. So we're not going to know if they really have the disease. So this denominator, this number, the number of people infected, we don't know that for sure. So let's take a look at this example. So building off the previous one, if we knew that 100 people were sick and we tested those people, so those are the 100 people with symptoms, and still 10 people die. So the scenario looks just like the last time where we had 10%, but there's a hidden 100 other people that have no symptoms. So if we looked at the case fatality rate now, because we have these 100 people that have no symptoms and we don't know, and if we're not testing them, we wouldn't know them. So that would be 10 over, now it's 200. So our denominator has changed. And so now our case fatality rate is 5%. So it's less deadly than the other case. So if you don't know how many people are actually infected and you don't know to test them, this case fatality rate can be misleading. And that's what we're finding right now. So maybe the case fatality rate might be less deadly because there's more people that are infected and we just don't know. So that's one of the problems with case fatality rate. Now, the next thing is the case fatality rate constant? Okay, so that one, no, it's actually not constant. But can you guess why it's not constant? Any ideas? So why wouldn't the case fatality rate be constant? The number changes of uninfected, yeah. All right, and take a look at this picture. The case fatality rate changes based on our individual and our social responses to how soon we receive treatment. If you're sick and you're not going to the hospital and you stay at home, you're probably you have a higher chance of dying than if you're sick and you go to the hospital and you receive treatment. So these are some things that can change the case fatality rate, because being sick and staying home and not doing anything about it versus being sick and trying to receive treatment, that can really adjust, are you going to survive or not? So those are things that can determine if the case fatality rate is higher or lower. Now, during an outbreak, it can be very difficult to measure the case fatality rate. So take a look at this right here, and this is provided by Hawaii Pacific Health. So when you have COVID-19, you start off with getting a fever, and then you get a cough, and then other things happen, you get admitted to the ICU. But if you die, you don't die until the 19th day. So 19 days after symptoms appear, will you die? That's almost 3 weeks. Okay, so if we are, let's say right here at day 8, if we look at day 8 and we say, let's try and calculate the case fatality rate, we're going to say this person is a survivor. On day 10, they didn't die. So we say they didn't die, it makes it seem like the disease is less deadly. But if you were to wait 2 more weeks, this person would have eventually died. So by measuring the case fatality rate in the middle of an outbreak, we're not accurately measuring the people that will die in 2 weeks. So it's difficult to accurately measure this thing in the middle of an outbreak. You can look at when the outbreak's over, you can say how many people actually died, then you get a better estimate. But in the middle, you have all these people who are going to eventually die in another week or 2, but we're counting them as survivors. So that's another thing to keep in mind when looking at case fatality rates. Now you may have seen this, in different countries, we have different case fatality rates. So there's a huge variety of case fatality rates, from Italy and the UK to 12–13% of case fatality rate. So 12–13% of people are dying that get infected. To the US, we're at 4%, Germany, South Korea, 2%, Singapore is at 0.3%. They only had 10 deaths out of over 3,000 cases. There's a huge variation in the death rate. So why would some of you think that there's such a variation from 0.3% to 13%? Any ideas? Implementing social distancing, reaction to the virus, stay at home, healthcare standard differences. Yeah, there's so many things we just don't even know. There might be demographics and ethnic makeup of the different people, more testing. Really, there's just so much that we don't know. And this is one of the unanswered questions that we're trying to figure out right now. Why is there such a variation? If we know what Singapore is doing right, then maybe we can implement some of that across the world so that we can bring death rates down as well. But the short answer is that we don't know. In the middle of this disease, there's so much that's happening. Just think back to a month ago. You know, no one really thought that everyone wearing masks was required because we didn't realize how bad the asymptomatic cases were, people that had the disease but showed no symptoms. So there's a lot that we just don't know. Also, you may have seen something like this, that it varies by age. Younger people are less likely to die of the disease than older people. And so this is data of the US from mid-February to mid-March. I didn't have the data yet for the US for the next month, but at that time, no one under 19 or under 20 died. Very few people died from 20 to 44. The next, it starts increasing, 1%, 2%, and then when you're above 84, 85 and above, you're 10 to 20 to 30% likely to die. So there's a huge variation from very, very low to much higher. So the case fatality rate, if we're looking as a whole, as a nation or as a world, it varies by looking at different age breakdowns. Now, the other thing that we want to look at was how contagious a disease is. So we call that the basic reproductive number, and we denote it with this R0. We call it R0. So you may have seen this in things, even in movies, in the news. So R0 is the basic reproductive number. And the definition for this is the number of secondary cases, or really new infections, from one infectious person in a population that's fully susceptible. Okay, so you have one person that's infected. How many people does that one person infect? So if R0 is less than 1, the disease will die out. If R0 is greater than 1, you'll have an outbreak. Well, if you say R0 is less than 1, you're thinking, well, okay, if it's less than 1, it has to be 0. But R0 could be something like 0.9. So if you're thinking 0.9, well, what does 0.9 people mean? Is that like from the shoulders down? No, 0.9 people is just on average. So maybe we don't have just 1 infected people, but we have 100 infected people. So if you have 100 infected people, then that 0.9 represents 90 people get infected. So even if you have 100, then you go from 90 and it goes down. And so that's where it will die out if you have less than 1 R0. And if R0 is greater than 1, we do get this outbreak. So if R0 is equal to 1, this is what it looks like. You have one person infected, then the next day they infect one other person, the next day they infect one other person, the next day they infect one other person. So you start off with 1 infected person, and in 3 days you get a total of 4, right? That's simple enough. One person infects another, infects another. If R0 is 2, this is what happens. One person infects 2 people. That's what R0 of 2 means. But each of these 2 people get 2 more people infected. And each of those new people get 2 more people infected. So in the same 3 days, it took from 1 to 4. With R0 of 2, it goes from 1 to 15. So in 3 days, we got 15 infected. And now you might be wondering, well, 3 days, that's a little too quick. So maybe our time scale doesn't have to be days. It could be maybe in 10 days or something, or depending on how long it takes for disease to spread. But also, if you're thinking of maybe just days, something that spreads very quickly might be rumors. So the way that a disease spread is the same way rumors spread or ideologies spread, right? Someone tells you a rumor, and then you tell 2 people that rumor, and then each of those people tell 2 more people that rumor, and that's how it spreads just as quickly as a disease can spread. So let's take a look at this R0 equals 2. How many people, and write your answer in the chat. So day 1, we had 1 person, or at start, we had 1 person. In 1 day, we had 2 people. And in 2 days, we had 4. In 3 days, we had 8. How many people are going to be on the 4th day? How many new infections? And write this in the chat. Let's see what you have. How many people do you think are going to be infected on the 4th day? 16. I'm hearing 16. Good. All right. Several of you were really quick to jump at 16. Yeah, 16. And how did you come up with 16? Yeah, you're just multiplying your previous day number times 2. Oh, I see another one.
2 to the exponent. I like that one. So at 0 days, at the start, it's 2 to the 0. And if you remember, anything to the 0 is 1. So you start off with 1, and then at day 1, 2 to the 1, that's just 2 people. 2 to the 2, that's 4 people. 2 to the 3, that's 8. So we can figure out at any given day. So we can figure out on day 10 how many people are infected. That'd be 2 to the 10. So this is the formula. 2 to the n power, 2 to the number of days. This is what we call an exponential function. So let's look at R0 equals 1 and R0 equals 2 graphically. So this is what R0 equals 1 looks like. You start off with 1 person, and the next day 1 more person gets infected, so you get 2 the next day, and so forth. So come 30 days, so in 1 month, you're going to go from 1 infected person to 31 infected people. Okay? That's bad, but it's not as bad as it can be. Let's take a look when R0 is 2. Remember, we started off in 3 days, we already had 15 people infected. So this is what it looks like. And this is kind of that exponential curve you may have been seeing in the news, right? It goes up like this. In 30 days, with an R0 of 2, we get over 2 billion people infected. Okay? That's 9 zeros. 2 billion people infected after 30 days. And we started off with just one person infected 2, each of those 2 people infected 2. And just to look at this scale, right? If this is 2 billion, that's 1 billion. Way down here, that's 1 million, and it's like 1 pixel high is it's like 1,000. That previous slide right here, this 31 is compressed all the way down here. So it looks like it's practically 0 compared, 31 compared to 2 billion is basically 0, okay? So it's huge. So when you have an R0 of 2, it can easily run away. It looks like it's not too bad, right? Just 2 people get infected, but over time, you're gonna get a lot. So 2 billion people in 30 days. Now, when people calculate R0, they wanna look at certain things. They wanna look at the time that an individual is infectious. They wanna look at the contact rate that the infected people have with people that are healthy. And they look at the likelihood of an infection when you have a contact with these susceptible healthy people. Now, with R0, having more people in a room can increase R0, but following measures to protect yourselves, such as hand washing, avoiding crowded places, and other recommendations by health officials can decrease R0. So R0 is not necessarily constant. We can change R0. So here's some R0 values for some well-known diseases. Measles, R0 is 12 to 18. And again, Dr. Rick, if you were at the talk this afternoon, did show some of these values. So measles, R0 is 12 to 18. Remember, an R0 of 2 means 1 person infects 2 people. And each of those 2 people infect 2 more. So a measles, R0 of 12 means 1 person infects 12. Then each of those 12 people infect 12 more. So in 2 days, you're already gonna have over 100 infected people with measles. Chickenpox is 10 to 12. So one day you have 10 people infected. The next day, each of those 10 people will get 10 more people. So these are huge numbers. Polio, 5 to 7, mumps, 10 to 12, smallpox, 3 to 6. COVID-19, it's still early. It's between 1.4 and 5.7, but more realistically, people are getting the number between 2 and 2.6. So we can say it might be like 2.5 if you want. HIV/AIDS, 2 to 5. Just the common cold is 2 to 3 is your R0. So the common cold, if you're sick, you're gonna get 2 to 3 people sick as well. The Spanish flu that devastated the world 100 years ago, that was 1.4 to 2.9. And just our common flu that we get every year, depending on the strain, it's going to be 0.9 to 2.1. So there's a huge variation in R0s. But think about measles, okay? Or any of these, even like the influenza, if it's at 2. Remember, we said we start off at 2 with R0 of 2. You can get 2 billion people infected.
So, and you have something like measles that's 10 or 12, and chickenpox is 10. Why don't we see the entire world infected with chickenpox or measles if things are that crazy? Any ideas? Go ahead and put it in the chat. Vaccines, good. All right, vaccines. So taking vaccines or having vaccines can really reduce this and prevent 2 billion, the whole world from catching measles. So let's do an example. So if our R naught is 2, remember R naught 2 means that on average you're going to get 2 people infected that you come into contact with. So if you come into contact with 10 people, how many people do you get infected? You're going to get 2 people infected, right? So that R naught of 2, and if 10 encounters, you're going to get 2 people infected. That means you have an infection rate of 2 over 10 or 20%. Okay? So R naught of 2 means you get 2 people infected, and if there's 10 people you come into contact, 2 of the 10 are 20%. So let's say this disease, each person that I come into contact with has a 20% chance of being infected. 20% chance. Now, if I vaccinate 2 people, so 2 people are vaccinated, that means 8 people are susceptible to the disease. And each person is 20% chance of being infected. So 20% times 8 would give me, 20% times 8 gives me 1.6. So 1.6, that's the number of new infections. And that's what R naught is. So what I've done is by vaccinating these 2 people, the chance of infection is still 20% for everybody. But now, instead of vaccinating or coming into contact with 10 people, I only come into contact with 8 people. That's how we get 1.6. So R naught has then been reduced from 2 to 1.6. Remember, 2 is where we got it all the way to 2 billion. Okay, so 1.6, that's getting there. If we got it down to 1, then that's really great. We're not going to have an outbreak. How could we get it down to 1? How can we get R naught down to 1? Well, what we had was our R naught, this new R naught that we had was 20%, and go back to here, right? 20% times the number of vaccinated, or number of contacts. So 20% times the number of contacts. So if I had 10 total people, but if I remove certain vaccinated people, and I want that to equal 1. For those of you that are good with math, how many people should V be? What's the value of V to make this equation equal to 1? Let's see in the chat. So I want to reduce R naught to 1. What value would V be to get this equation equal to 1? 5, all right, good. All right, you're all really fast. 5 people vaccinated. So if we had 5 people vaccinated, then there's a 20% chance and there's a 20% chance of infection. 20% times 5 is 1, so our new R naught is 1. Only 1 person will be infected if we vaccinated half of the people. 5 of the people, you're only going to get 1 vaccinate, or only 1 new infection. It's okay, you have 1 new infection, it's manageable. It's not going to blow up on you. So that's what happens. So we got this number. Remember, we got that from that percent, R naught over the total population. That's where we got 20% times the number we can infect. Our population minus the number of vaccinated people. And if we equal that to 1, then we have this expression right here, this equation, to describe what we need to have to bring down our infection. If we rearrange this term, I'm not going to show you how, but you can rearrange it. We can write this expression like this. And what this expression says is that the ratio of vaccinated people over your total population, so the percent of your population that's vaccinated over total population, if we can bring the vaccinated percent to be equal to this number, 1 minus 1 over your R naught, then that means on average, for every infected person, you're only going to get one new infection. That's how we get our new effective R naught equal to 1. So if we're able to get the number of vaccinated people over the number of total people to this ratio, this number, then we'll be able to control an outbreak. So by doing that, we then protect people. And this is something that we call herd immunity. So by getting enough people protected, we didn't vaccinate the entire population, but we vaccinated them up to this certain threshold, called a herd immunity threshold. Then we can protect the population collectively. We're not necessarily protecting every single person because some people are still going to get infected. R naught of 1 means you infect one person. So some people will still get infected, but as a population as a whole, we won't have to shut down and worry about everybody being infected with that 2 billion people. So by getting enough vaccinated people, we can control this. So here's the herd immunity threshold for some of these diseases. So measles, when R naught was 12, you need to get 91.7, so almost 92% of the population needs to be vaccinated for measles. Smallpox, you need, when R naught is 5, so just with an R naught of 5, you gotta get 80% of the population vaccinated. For mumps, when R naught is 4, you gotta get 75%. So the flu, when R naught is 2, you gotta get half the population. And that's what we're writing it right now. With COVID-19, we said R naught's probably gonna be like 2.5 is divided for R naught. We're probably looking at like 60-ish% to be vaccinated, but there's no vaccine yet. But when we do, we're gonna need to have a huge number to be able to control this. And why do we need herd immunity? Instead of just saying, well, why don't the people that want to be vaccinated then get vaccinated? And that's true. People that want to be vaccinated should get vaccinated, but there's a problem because not everyone is able to get vaccinated. So we have people that aren't able to be vaccinated. And these are people like, I just had a little baby, he's 7 months old. My sister and my other sister-in-law gave birth. They all have very young children. They're too young to get vaccinated for the influenza and all these other diseases, their MMR. And so by having enough people around them vaccinated, having enough people around them protected, then these children don't have to worry about being vaccinated because they're too young to get vaccinated. And also, there are other people that are immunocompromised, people that are on getting transplants, organ transplants. They're not able to get vaccinated, and so they rely on everyone around them. You don't want to have to live in fear of just going to the grocery store because the people around you didn't get vaccinated, and you're not able to. So that's why we get vaccinations, not just for us, but for the people around us that can't get vaccinated themselves. Other things that you've seen in the news are stuff like flattening the curve. So what does that mean? If you look at this, maybe someone might try and figure this out. Maybe the area under this curve is actually equal to the area under that curve. I'm not sure, but maybe they are, and that represents the number of people that are infected. So people are saying, well, why don't we just all get infected right now, get it over with, bang it out in 2-3 weeks, everybody will be infected, then we can get back to life as normal. We don't have to shut down. We don't have to be unemployed or stay at home or whatnot, as opposed to something like this where you stretch it out and you're not going to have school in the fall. You're still going to be at home. You don't want to be quarantined anymore. So what's the difference? And having a really fast, quick, getting it over with may sound nice, but the thing is that when you're sick, especially when you're really sick, you're going to end up in the hospital. And there are limits to hospitals. There are only a certain number of hospital beds, especially ICU beds and ventilators. So if we get so many people sick so fast, our healthcare system is not going to be able to handle that. And that's why we're trying to spread out this, or what we say is flattening the curve. So an example of this was in 1918, the Spanish flu pandemic. Look at 2 different cities, St. Louis and Philadelphia. So they got their first cases about the same time of the Spanish flu. Now, when when Philadelphia got their first case of Spanish flu, or really the first death, they continued on life as normal. They had this huge parade. This is during the war. They had this big parade. I think it was the Liberty Parade. But about 200,000 people came out to the city. They flocked to go to the parade. They carried on life as usual, even after the first death. And you see the number of deaths increase, or this is really the death rate. So the number of deaths per population. So it accounts for the difference in population. So Philadelphia had way more people dying really quickly before doing something. So it took Philadelphia 2 weeks before they implemented any sort of thing like social distancing, as we would call it now. On the other hand, if you look at St. Louis, 2 days after the first death in St. Louis, they started canceling things. They started canceling work and gatherings and basically doing social distancing, as we would call it today. So in a matter of 2 days, Philadelphia, or excuse me, St. Louis was able to flatten this curve, whereas Philadelphia had this huge increase. So this is an actual scenario from 100 years ago of two cities. Now, shifting gears a little bit, how bad would it be after you have one death? Let's do an example. So let's say the case fatality rate, remember this case fatality rate is the number of people who die over the number of infections. So if you have a case fatality rate of 1%, that means that 1 out of 100 people are going to die. So if one out of 100 infected people die. So if one person dies and we have a CFR of 1%, then we know there are 100 people infected. So by the time it was announced that the first death happened, there's probably 100 people that were infected. However, that 100 people infected, remember from the other slide where I showed you the timeline of when they started having coughs and all these other things? This 100 people infected was in their 3rd week of infection. So there are 100 people, when you have one death, there are 100 people that are on the 3rd week of an infection. That means these 100 people were sick for 3 weeks. And each of those weeks, those 100 people were infecting more people. And those people that got infected were infecting more people. So you could easily have gotten 500, maybe even 1,000 people that are infected by the time the first person begins to die. And so that's one of the scary things, especially if you think about maybe the disease, there's a lot of asymptomatic cases out there. So, you can diagnose the people that have symptoms, but people that are asymptomatic, you might not know what's going on. How can you catch a disease? So what's a disease, or what are some diseases that you might think of? Go ahead and list it in the chat. Just give me some diseases that you can catch. The flu, good. What else? There are dozens of diseases that easily pop to my mind. Just seeing the flu. Measles, good. We talked about them all. The common cold, good. HIV/AIDS, good. Another one. Hepatitis B, smallpox. Yep. Okay, good. Everyone's putting them all now. Mumps, chickenpox. Good. All right. So there's plenty of diseases out there that you can catch. Now, a lot of these times to get a disease, you need to catch the disease. So what needs to happen? You need to have some sort of contact with an infected individual. It doesn't even have to be a person. So you might think malaria or dengue or Zika. Those are things that need to be transmitted with mosquito. There's other diseases. We don't have them in Hawaii because we don't have ticks, but other diseases where you might need to be contacted with a tick. So those are what we call vector-borne diseases. But we need to have some sort of contact with an infected individual. So how do diseases spread? How do we model this? We start off by having a susceptible or a healthy individual. And that healthy individual interacts with a sick person, a sick infected person, okay? Or a sick infected mosquito. A healthy person interacts with a sick person. And at some rate, when they interact at some rate, that healthy person gets sick themselves. And once you're sick, sometimes you might stay sick forever. Sometimes you might die from the disease. But a lot of times you get better and you recover. And you recover at a certain rate. And when you recover, you don't recover based off of any other interactions. You just, at some rate, there's a certain chance that you'll recover. So that's how we go. We go from being susceptible and healthy to infected and sick, and then eventually we're recovered from the disease. Going from infected to recovered, we're gonna ignore death due to the disease just in this instance. But that is another option if you want to do different types of models. So the number of susceptible people tomorrow, the number of new susceptibles, are going to be the number of susceptibles today minus the people that just got infected. So susceptible tomorrow, susceptible today, and you're taking away from your healthy population all the new sick people, and you take them away and you move those new infections into tomorrow's infected class. So tomorrow's infected is the number of infected today plus those new infections. But some of those infected people get better, and so we're going to take away those people that get better and then move them into your recovered. So recovered tomorrow's, today's recovered, plus the new people that recovered. But how do we determine the number of new infections? Okay, so for the number of new infections, what you're going to need is a susceptible person to interact at some probability with an infected person. So they're going to have some sort of interaction. But when they interact, you're going to have a probability that they'll catch that disease. So you're going to have an interaction with susceptible and infected people. And if you're going to look at all the susceptible people interacting with all the infected people, you're going to multiply. So all the susceptible times all the infected. And then with all these interactions at a certain rate, we'll call it rate 1, they'll be infected. So we're going to do another times. So rate times the susceptible people times the infected people. That's the number of new infections. This is just the previous slide, but now we're filling in what the new infections are. Okay. The new infections, or the infected tomorrow, is going to be the new infections, or today's plus the new infections, minus recovered. When you recover, you don't recover, well, if I'm sick, let's say with the flu, I don't get better by interacting with a healthy person. I don't get better from the flu by interacting with a sick person. I don't get better from the flu by interacting with someone who's recovered. I just get better at some internal rate. And that's why it's just that rate times the number of infected. All right, and then the recovered people tomorrow is just the recovered today plus the new people that recovered. Now, what's an outbreak? Go ahead and put it in the chat. What do you think an outbreak is? How would you define an outbreak? Not give me an example of an outbreak. Zombies is what I see. That could be a type of disease, actually. There's been, the CDC actually looked at a zombie outbreak in giving guidance for what to do. And the same guidance for zombie outbreak was the guidance that they would give during any other type of outbreak. So yeah, when you pass a certain threshold, when more than 2 people get infected, the rapid spread of the disease. Yeah, so all these are great answers, but essentially the number of infections increases. An outbreak is when you have more infected people tomorrow than you have infected today. So infected tomorrow minus infected today is positive. That's all we're trying to say. And remember, this is the equation from the previous slide, for the equation of infected tomorrow. So if I just move infected today, I subtract it to the left-hand side so I can look like this, we get this. So the change of infected, tomorrow's minus today's infected people, is the new infection minus the new recovered. And if that number is positive, we will get an outbreak. So just looking at this, we get an outbreak if this happens. Now you may notice that both of these terms have an I, and number of infected today. And what we can do is, since these are positive numbers that aren't 0, we can divide both sides by that and we get this final term. We can say an outbreak happens if the rate 1, that's the rate that someone gets infected, times the number susceptible is greater than the rate of recovery. Okay, so just keep this filed in the back of your mind. We're going to come back to this in just a moment. Now, what's a characteristic of an outbreak? So you've seen graphs like this before. And so an outbreak means you have an increase in infections, and then it goes down. Right? It goes up, it goes down. You get a lot of people, and then eventually it goes away, or it becomes endemic and stays with us forever. But it goes up and it goes down. So how does it go up? Well, remember, we said it goes up. We get an outbreak when we have this. The rate 1 times susceptible today is greater than rate 2. So that's how we can say when it goes up. What would explain it going down? We know it goes up, but what about going down? So if you recall back to the equation for susceptible individuals, the number susceptible today's susceptible minus the new infections. This number, if you are just taking away from that number, the number of susceptibles goes down. As you remove healthy people and they get sick, the total healthy people get smaller and smaller and smaller. And so as that susceptible number gets smaller, it gets so small that eventually the rate 1 times that S is not greater than this, and that's when it starts to go down. So that's why you get an outbreak that big increase and then decreases, and that's because this number keeps going down. So remember, we have an outbreak if the rate 1 times susceptible is greater than rate 2. If we rearrange this, so let's divide both sides by rate 2. We get this right here. So rate 1 times susceptible over rate 2, if that's greater than 1, we get an outbreak. This number is very important. It's very important. We call this number R0. So this is the mathematical way that we can find out what R0 is. So instead of having to track, okay, one person was infected, how many people did that person infect? And that's a lot of that contact tracing you might be hearing about recently. Okay, this person was infected. Who did she interact with? Who are the people that he or she went and interacted with in the store or at a restaurant or at school? They have to see how many interactions and then ask all those people to check in and make sure that they're okay. That's what they're doing right now. But in order, that's one way to figure out what R0 is. But this is the mathematical way through our models that we can determine what R0 is. And remember, R0 definition is on average the number of secondary infections, the number of people that one infected individual will infect. So there are many different types of math models out there. So there's SIR, that means you're susceptible, you're infected, and recovered. An example of that would be the flu, right? You're susceptible, you get the flu, and then you're recovered, and you don't get the flu again, at least that strain. A different type would be SIS. What's an example of an SIS model? Go ahead and write in your chat. What's a disease that you're susceptible, you get the disease, but then you're susceptible again. You don't have an immunity from it. The common cold, yeah, the common cold, you get the disease, and then you get better, but you can get the cold, 2 weeks in a row. Okay. So the flu, it's kind of like that, but the thing is the flu is it changes. So it's actually a different strain of flu. So the flu is more like an SIR type of model. What's a disease where you're just susceptible and then you're infected, and once you're infected forever? Good. HIV. Yeah, HIV/AIDS. Once you have HIV/AIDS, you have it for the rest of your life. Herpes. Those are things that once you get it, you're sick and you're infected forever, and that's it. So there are some diseases where you're susceptible and you're infected. Once you're infected forever. And then there's different types of models. So you can look at, we call this E, an exposed or a latent period. That's where you have the disease, but you're not yet showing symptoms or you're not yet spreading the disease. So think of like Ebola. So when Ebola happened, you may remember, you had to wait like a couple of weeks. Even right now with COVID-19, they're telling people, well, you gotta wait 2 weeks to make sure, because it's an incubation period, So you're not susceptible if you have the disease, but you're not quite spreading it yet. So that's different from when you have the disease and you're spreading it. So you have this incubation period where you're not susceptible, you're not infected, you're just in between. So it's an SEIR model. A variation, again, is if you have two different types of infections. Maybe that's two different strains. So you have a disease with two different strains, and one strain is more deadly than another, or one strain is more contagious than another, or maybe one strain, you might have different symptoms, asymptomatic. So there's various different things you can do to show, to add more complex, make your model more complex, which makes it more realistic. So this is sort of just an overview of how we can make these models. But yeah, are there any questions? So this will be put on YouTube. And if you do have questions, or just like you wanted to use some of the slides, some of the numbers, some examples to show with your students or your family and friends, just look for it on YouTube, on the library's website, UH West Oʻahu Library, as well as I'll be putting it on my YouTube channel as well. All right. Do I see any trend in terms of Hawaii, like trend? Well, in looking in trends in Hawaii, we're definitely, it's definitely going down. If you remember, like 2 weeks ago, that seems forever, but that was when we're getting, like, what, I think 20, maybe even 30 cases a day. And right now we're only seeing 2, 3 cases a day, 1 case a day. So we, through these different preventative measures that we've been doing, yeah, we are seeing a decrease in number of new infections, which is good. That curve is flattening, but you know, I am cautious that this is not going to stay forever. You know, if people lift restrictions too fast, then there's a whole nother thing called like a second wave, a third wave. And if you looked at Dr. Rick's talk this afternoon at noon, he did show an example from the 1918 outbreak. You can get a second wave, which can be even more deadly and harsher than the first wave. So, but yeah. Is the death rate for people diagnosed with COVID, including those who had underlying conditions? Yes. So the death rate, or the case fatality rate, does include those that have underlying conditions. And so that might also be one of the reasons why people that are over 85 will have a higher case fatality rate, have a higher death rate, because they have other underlying conditions. I haven't seen the actual data that's broken down on underlying conditions versus not underlying conditions, but I do believe that there is a correlation with underlying conditions and a higher case fatality rate. Yeah, so it does change. So that was a good question. Are there other questions? Are there any other variables one must consider? Oh, there's tons of variables. So with every disease, you know, there's a lot to just consider. Let's just even look at this SIR model. So if you have a vaccine, maybe that you can go from you're susceptible and you go all the way back, you go to your recovered. Once you get the vaccine, you're fully recovered. Or you might have a vaccine where there's only temporary immunity. So you're going from susceptible to this temporary immune class, but unless you get a booster shot, you're going to go back to being susceptible. Or you go from susceptible to recover with a vaccine, but maybe only 70% of the people get immune, and the vaccine is only 70% effective. So 30% of the people stay in the susceptible class. So I mean, you know, there's way more things that you can do to add to this model, and it's sort of a trade-off. The more realistic the model becomes, the more complex it becomes, which means the harder it is to make calculations and predictions. But I mean, depending on the model, depending on what you're looking for, sometimes part of applied mathematics and mathematical modeling is making simplifications. And so with applied mathematics, we work very closely with people in these different fields, and we work with epidemiologists and biologists and whatever field it is to make these trade-offs. Where can we make a sacrifice in terms of making it 100% realistic versus just getting a big picture idea of what's happening? And I've had many discussions with collaborators on that. Well, how can we, what's the trade-offs? I remember I went back and forth with one of my collaborators on like, oh, he's not going to like this. And when I said, no, I'm not, I'm not adding more to the model. And then he wanted it more realistic. And we went back and forth, but we eventually compromised. So you can always add more to the model, and it's just that trade-off. Some models have a lot more, and then they're running them on supercomputers right now. There are supercomputers working to model predictions of COVID-19 as we speak. I know several different people across the country are using those to do that right now. But yeah, thank you. Other questions? And thank you all for coming out. I know it's late in the evening, especially if you're coming in from like New York and it's 11 p.m. But there are other talks if you're interested in them. Are there other questions? I'm happy to answer any questions you may have. Yeah, good to know. So again, just kind of roughly basing it off of this, we're probably going to need 60% of the population vaccinated, and vaccination is going to be hard. Normally it takes like 1.5 years, I want to say, to get vaccinated. Our country has, I believe, hundreds of thousands of hens that they have just for vaccines, and there's actually a national security issue. And so they don't disclose where those hens are. They don't even disclose how many people how many hens we have, but we have a bunch of hens that are guarded, that are armed guarded, that are producing eggs. And most of the time we don't need those eggs, so those eggs end up becoming fertilizer. But when we do need those eggs, like right now, those eggs then become vaccines. But we first have to develop the vaccine. But once we've developed a vaccine that we know works, then we have to then create that many. And if you're thinking about 60% of the whole world population, or just even of the US population, that is a lot of vaccines. There's so many vaccines. And then who do we vaccinate first? These are questions that we really haven't had to address. Other times where we're, like with the flu or the MMR, if people have just been getting the vaccine as needed. But now if you're trying to vaccinate 60% of the population or even more, who gets first? First responders, grocery store people, gas station, if you just think about essential workers, how many essential workers are out there right now working? And there's quite a few. Do you vaccinate the elderly, which seem to have a higher case fatality rate? So you're looking at, who gets vaccinated first. There's a whole big issue, and vaccination, that's a whole nother issue that will take a whole nother presentation. But just to know, once we get about 60% of the population vaccinated, that's probably where you're going to feel more comfortable with everything. Yes, and this is if the vaccine is 100% effective. Yes, so thank you for bringing that up. Those numbers were if the vaccine is 100% effective. So like the flu vaccine, depending on the year, it can be like 50% effective, it can be more, it can be less. We really don't know. The thing with the flu is they try to guess what's happening, what that strain of the flu is going to look like that year. So they make a couple of guesses, and then they put all those different guesses together into one vaccine. Sometimes the vaccine ends up evolving into that. Sometimes it's not, but we do. That's why the flu is not always effective. But other vaccines that are much more effective, like the MMRs, because those don't change like the flu changes every single year. But yes, so So that number is assuming that the vaccine that we have is 100% effective, that COVID-19 doesn't start to evolve and change, because otherwise you've created a vaccine for a strain that no longer exists, and now we have a different strain. So there's just a lot to think about, especially in the middle of a pandemic, of this outbreak. There's a lot that we don't even know. Just think about where we were a month ago, or 2 months ago, or even 2 weeks ago. So there's a lot that's happening. Good. Other questions? All right, thanks. Good night.